Good evening, sir. Rudrajit here.
Good evening, Rudrajit. Good evening.
Sir, we are live.
Okay, right.
Not
Great.
Yeah.
I'll just wait for Dr.
Sure.
Manoj Roy to join, and then we'll. Evening, Rudrajit. Evening.
Hello.
Hello.
Sir, I think Dr. Manoj sir has joined.
Please join. Manoj, have you joined? Hello there, Manoj. Have you joined? So we'll wait for Dr. Manoj Roy to join.
Yes, sir.
And,
Sir is joining shortly. Sir will join, sir.
Okay, fair enough. So essentially what it is that we are going to be discussing everything about rectal, anorectal, and rectal carcinoma. It's important to realize why we discuss this topic separately. So I'm going to ask Dr. Manoj Roy, who's a very, very experienced colorectal surgeon, an oncologist, a surgeon, who's an oncologist, a surgical oncologist. He was till very recently, he was the surgical director of the Tata Cancer Hospital. Huge experience, and he used to run their colorectal department, the colorectal branch, and man of many parts. He is also an examiner for the Royal College of Surgeons of Edinburgh, has been an examiner for quite some time, and he is presently one of the organizers of the examinations, which is run in Kolkata, and he does it with aplomb. He's done a wonderful job. We just finished the local diet of the Royal College of Surgeons of Edinburgh, and he has been also instrumental in getting the course, the OSCE course, started out here. So, Manoj, I can see that you've joined.
Can you see me?
I can't see you. For a start, I'm going to put my video on so that people know who I am. And Manoj, I think, can you turn your video on as well?
So I'm trying my best. Select the camera.
I'm sure people who are joining would love to see you.
Unable to start video. Actually, I have just 1 minute. I've not been on the Zoom for a long time.
Okay, that's all right. See whether you can give it another try. Otherwise, um,
Can you hear
uh,
me?
yes, we can hear you absolutely loud and clear. So I'm going to turn my video off because people don't need to see me.
I just don't know how to switch on video.
There is a sort of a little button at the bottom just beside
Where?
the audio.
It is saying please check the device and connection and try again. Something wrong with my laptop? I don't know.
Never mind. If we don't have the video, you can always post a picture of yourself. I think all the people who are there would love to see you. But shall we start? It's
Yeah, yeah, okay, let us start.
3 minutes past 8. So, as I was telling them, so I'm going to introduce Manush, Dr. Manush Roy, past surgical director of the Tata Cancer Hospital, spent a huge amount of his uh,
Uh, Sir,
experience. I mean, yes, hello.
sir, Dr. Manu sir can on your on his video now.
Video.
Yeah, yeah.
It is saying unable to start video at this time. I don't know what is happening. Sorry. I think
That's all right. If he can't, that's fine. I mean,
that's okay.
but okay. So it's since it's about 4 minutes past 8, so let's start.
Uh,
And just to introduce, I'm Dr. Sanjay Bakshi. I'm uh, visiting consultant in the Department of GI Surgery at CMRI Hospital and Woodlands Multi-Speciality Hospital. And I'm this evening talking to Dr. Manush Roy, who's one of the most, has a very high experience of uh, GI surgery, oncologic GI surgery, and uh, working at the Tata Cancer Hospital. Huge turnover at that point in time, and he used to be mentoring uh, the GI surgery unit of that department, and he spent a lot of his time working with colorectal carcinomas. So, and in addition, as I said, he's been an examiner for the Royal College of Surgeons of Edinburgh, and in addition to that, he wears another cap. He's one of the organizers of the Royal Examinations being run in Calcutta for the past few years, and he's done it with great aplomb. And as a result of his efforts, the Royal College has decided to make Calcutta one of the permanent centers for its examinations. And in addition, they are running an OSCE course possibly in April. Dr. Manoshra, is that right?
July, I think, July.
July. Okay, right. Fair enough. So today the topic is going to be rectal carcinomas. So for a start, I'm going to ask you, Dr. Roy, the colon is such a huge, long um, organ. You know, starts at the cecum, ends at the rectum. So why is it that we are not discussing the colon and we are discussing rectal carcinomas? What's so unique about rectal cancer and its management?
Okay. Can I share my screen?
Yes, of course you can. I've arranged for you to share your screen.
Entire screen. My God. Something wrong with me. I don't know. Wait.
You should be able to share your screen. I've opened
Share.
it up for sharing.
Have to click the share screen at the
Yes,
bottom, right?
that's right. Yeah, absolutely right.
But on my choose what to share with app.zoom, it is coming. The share is disabled. Only cancel is coming. I don't know what mistake I made.
I have actually opened it. Who can share all participants? Yeah, I think we are there.
Your
Yeah,
screen sharing.
yeah, there we are.
Can you see the
Yep.
PowerPoint
Yes,
now?
sir, I can see your PowerPoint. Absolutely.
Okay.
Bang on. You
Yeah.
just need to put it into the, yep,
Now?
there we are. Fantastic.
Okay. Thank you. Okay. Right. So basically, the question that you asked me that it's a long organ, and what is so unique?
Um,
So making it
uh,
very very simple, the embryological origin is little different, and in contrast to the colon, whose venous outflow goes to the liver, rectum it also goes to the liver, portal vein, but it also goes to the pelvic side wall veins. Thereby, it can bypass the liver to enter the systemic circulation into the vertebral column and the lungs. Similarly, its lymphatic drainage is also different. It can also spread to the pelvic side wall and the inguinal node if it is a very low rectal cancer. In contrast to the colon, it is confined in a very tight space, the bony pelvis. The surgery is very difficult, and it will be a pity if we get a positive resection margin. That's why it is such a difficult cancer to treat.
So, in a sense, what you're saying, it's a place where which has a very difficult and unusual anatomy.
Yes,
Is that
absolutely.
right?
Yeah. That is true.
So, Dr. Roy, how does one approach to treat a patient with a rectal cancer?
Okay.
How would
So
you go
I'm
about it?
making it very simple. Say, for example, a patient comes to us with a rectal bleeding, and we do a per rectal examination. We find a mass. Possibly, first thing that we should diagnose, unless proved otherwise, is a rectal cancer. So the patient is sitting next to me in my opposite the table. We order the routine blood tests like CBC, electrolytes, liver function test, PTINR. But it's also a good practice to send blood for the carcinoembryonic antigen (CEA). It is a
And why is
tumor.
that?
Uh, it is a tumor marker. Its main role is to follow the patient after the surgery when they are kept on long-term surveillance. Its preoperative level is perhaps not that important. It's more of to this. Amongst all the cancers, the colon and rectal cancer are the better ones. And if we can detect a recurrence early in the liver or the lungs, we can still treat with a curative intent. In that respect, CEA comes very handy to us. That is the reason. Next investigation that we should always do is a colonoscopy. And
Can I just step in out here once,
sure,
Dr. Roy?
sure.
It's a rectal cancer. I have put in a proctoscope. I can see the edge of a fungating mass.
Yes.
So why do I need a colonoscopy in addition to this?
Okay, that's a tricky question. Uh, Mainly because to see the proximal colon, in around 2 to 3% of patients, there can be a synchronous lesion in the colon. So, if the patient may have a right colon cancer with a rectal cancer, then the treatment is different. That is the only reason why we should always see the entire colon.
Right.
If the tumor is rather big and the colonoscope cannot pass through the tumor, then the recommendation is we should do the surgery. And after the surgery, within 3 4 months, we must evaluate the proximal colon with the colonoscopy.
Thank you for telling me that. I was about to ask you that. Um, so, I mean, that's the message. I mean, you need to visualize the entire colon, isn't it?
Yes, absolutely.
Because we've seen a multiple number of times the presence of synchronous cancer. So it bears knowledge. So, um, in a stomach, you would take a geographical biopsy. Do you
Yeah.
do the same with a colonoscopy?
Yeah, at least 3 4 biopsies should take. The other thing I wanted to show by this diagram is that these days we hardly use the rigid sigmoidoscope. we use the flexible colonoscope. Now, where the rectum ends and the colon starts is a matter of debate. The definitions can vary between the Europe and the Japanese publications. The standard Western definition is if the lower limit of the tumor on rigid sigmoidoscopy is within the 15 centimeter from the verge, that should be considered as a rectal cancer and not a colon cancer. But we hardly use rigid sigmoidoscope, and in colonoscopy the problem is the first mark starts from 20 centimeter. So when the patient comes to us saying that the tumor is at 10 centimeter on a normal colonoscope, it can be 12, it can be 13. That is the something we should be aware of.
So that is something that is rather tricky, isn't it?
Yes,
Because it depends completely on your friendly uh, medical
endoscopy.
gastroenterologist who's
Yes,
done the colonoscopy, unless you're doing it yourself like we used to do in the UK. I mean,
that's true. Yeah,
in the
absolutely.
UK, the surgeon himself would actually do the colonoscopy, which I think it might not be a bad idea. What do you
Yeah,
think?
because we have to plan the surgery. And if it is a lower sigmoid upper rectal cancer, then the debate start whether the patient needs a neoadjuvant treatment or we can be taken up upfront for surgery. So these days the MRI has come to our help.
Okay, so how important is an MRI? Why not a CT scan? I am claustrophobic. I do not like lying in a, I don't fancy lying in a tunnel for about 45 minutes.
Like,
So
okay,
what's the advantage of the MRI over a CT scan, for example? A CT scan, I can get it done in 10 minutes and be off the gantry. So why an MRI?
so next, I'll before I come to it, I'll just take one slide on this. So the standard cross-sectional imaging to stage a patient with rectal cancer is still the CT thorax, abdomen, and pelvis. If you scan the literature, there is very little evidence to suggest that the PET scan can actually help. So, simple thing, simple CT and an MRI pelvis is enough to stage a rectal cancer patient. Now, coming to your question of claustrophobic, um, MRI is like the Google map to the pelvis. The anatomical clarification is much better in MR as compared to the CT. So I will take you through a few of the slides of MRI pelvis as pertaining to rectal cancer.
Right.
Now, can you see the two greater trochanter? So the field of view (FOV), as the radiologists say, has to be very narrow. It is not a bird's eye view of the pelvis. That so we should be very careful who does the MRI for the rectal cancer. So this is a transverse or cross section or axial view. So just a T2 image is good enough. No need for T1, etc. No need for diffusion in the initial staging. Just a T2. In T2, the water liquid appears as white. This is a bladder. These are the seminal vesicles, and this is the rectum. This is the mesorectum, and the muscles. This is the piriformis, and this is the obturator internus. Now, if the tumor has gone into the piriformis, patient usually have back pain and all, and it suggests a irresectable disease. And we must look into this area for the pelvic side wall nodes. Next that we see is the sagittal. Once again, this is the bladder. This is the anal canal. This is the rectal mass, and this fatty tissue is the mesorectum. Okay. And so I'm coming to your question. If the colonoscopist hasn't given a exact depiction of the height of the tumor, so here's what the Japanese follow. So on the MRI, the S1, and this is the first sacral vertebra. This is the second sacral vertebra. S1, S2 junction. If the tumor is within this, then it should be considered as a rectal cancer. If above that, it is considered as the colonic cancer, and this is what's getting very popular in our setup too. So a
Uh,
sagittal view of
Dr. Roy, what happens when you have a tumor straddling it?
straddling it, it should actually be considered more of a colonic because the peritoneal fold comes like this, right? So
Right.
that opens another pathway for the spread of the cancer. So that strictly, it is not really a rectal cancer. It should be considered as a colonic cancer,
So
unless,
any spread above that S1, S2 junction
yeah, that's a
should make it more colonic rather
more
than
colonic.
rectal.
Yes, 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 yes.
What
Plus,
if the major part of the tumor is below and a bit above? So, like we do for a G junction tumor, the
tumor.
COAT 1, 2, and 3. So, is there anything like that in?
Yes. See, if you, it's essentially to do with the mesorectum. In the upper rectal tumor, the mesorectal fat is huge, and it's very uncommon for the posterior mesorectal fascia to be involved by a upper rectal tumor. But if it's a big tumor, lot of nodal disease, then it should be considered as a upper rectal cancer, not a colonic cancer. And
Right,
in a lot of radiotherapy trials, they have included upper rectal cancer, the preoperative chemoradiotherapy.
right.
So I showed this just to make sure how useful the MRI is. If the colonoscopy has not given you the right height from the anal verge, MRI comes to our benefit. Now the
Um,
third, yes, go
yeah,
on.
yeah. Does it show the lateral spread as well? I mean, better than the CT scan?
Yes, 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 much better, much better, much better. All soft tissue tumor. So third section that the MRI does is the coronal. So here is the gluteus maximus. Here is the origin of the piriformis. That is the sacrum. More importantly, when we come front, the coronal the more front, this is an excellent view. So this is the levator ani muscle, the pelvic floor, which becomes the external sphincter. This is the ischiorectal fat, and this is the obturator internus. So if this tumor has invaded the levator ani muscle, the patient needs a AP resection and not a low anterior resection. This is the beauty of doing a MRI.
So you can predict the sort of surgery that you can offer the
What can
patient as well.
yeah.
Right.
Now my love with MRI has not finished, even if you are claustrophobic. Now,
No.
what are the things we look for in the MRI pelvis on the rectum? And this is very important, extremely important, because the rectal cancer is one of the most confusing cancer in the abdomen. We look for the T stage. For example, how much has the tumor gone beyond the outer muscle, the depth of the tumor. So it can be T3, A, B, C, D. I mean, students can read up. How far is it from this is the mesorectum, or mesorectal fascia? How far is it from the tumor? The distance here. Third, we see presence of lymph nodes. How many? And if the lymph node is heterogeneous in MRI, if it is round, more than 7 millimeters, definitely cancerous. MRI is that sensitive, but CT is not. Fourth is these are the veins in the mesorectum. Are there tumor thrombus inside the veins? That is called as extramural vascular invasion. So these four or five things we must see in the MRI. Otherwise, we cannot do justice to a patient with rectal cancer. So this is one of our patients. So I have drawn a cartoon. Here is assuming the tumor, and this is the CRM or the mesorectal fascia, outer layer where we will put our surgical dissection. Now, if the tumor is very close, we will leave behind the tumor. That is a bad surgery, and that is the challenge of rectal cancer surgery. And hence comes the importance of the MRI in staging. And we can give preoperative radio or chemotherapy to shrink the tumor and then operate to achieve a negative margin. And hence, MRI is extremely important investigation. Okay. Now I talked about EMVI, extramural vascular invasion. This is getting more and more prominent and importance, much more than the mesorectal node, because if it is positive, there is presence of tumor thrombus in the veins in the mesorectum. The chance of synchronous or metachronous, when after a year or so, it increases by 3 to 5 times more than those patients in which EMVI is negative, suggesting that even if you have done a fantastic radiotherapy and surgery, but patients are more prone to systemic failure. So these patients may benefit some with a new adjuvant or preoperative chemotherapy. I'll discuss more later, but these are the important things that we should look into preoperative staging MRI.
So that's a very important part of MRI in the pre-op staging, isn't it, Dr. Ravi?
Absolutely, absolutely. CT can't give all this information. Okay.
Right.
Yeah.
So essentially, you have a disease where you have an extramural vascular invasion, EMVI. So what are the surgical principles, and how would you approach this patient? Neoadjuvant chemotherapy, neoadjuvant chemo radiation,
Okay.
followed by surgery, or upfront surgery, and then follow on with adjuvant treatment. So what would your plan be?
I'm just speaking a very general knowledge kind of discussion today. Now, adjuvant chemotherapy has been studied in after colectomy, but there has not been a single trial where adjuvant chemotherapy has been tried only on rectal cancer. Whereas because colon and rectum are one organ, people have extrapolated the studies of adjuvant chemotherapy after colectomy for colon cancer to rectal cancer.
Right.
Of late, there have been a lot of systemic reviews and meta-analysis where there are doubts that if patient have received neoadjuvant chemoradiotherapy, there is little benefit of giving adjuvant chemotherapy. Okay,
Okay.
uh, but I would like to speak more about these things later. But before that, I would like to speak more on the surgical management.
Okay. Right. Sure. What are the surgical principles in the management of rectal cancer then?
Okay. Now, the principles, the sea change that has happened since the days of Ernest Miles is those days, maybe 100 years ago, the belief was the rectal cancer spreads downward distally. So the APR or APE was the very, very commonly done. But later on, it was realized that the bulk of the spread is cranially, proximally. So no need to do AP resection even for low rectal cancer. This is the sea change which happened over the years, which the students must uh, know as a sort of general knowledge. Now, the principle of surgical principle is what, as from Mr. Heald's publications, is this is the rectum, and this fat is the mesorectum, and this is the mesorectal fascia or the MRF. This is the axial view I've shown before, and this is a sagittal view. This is a tumor, and this fat is the mesorectum. So, what has become popular over the last, say, 30 years or so, this entire mesorectal fat has to be removed. That's called as total mesorectal excision. And hence, when I was a student and it was difficult to operate in the pelvis, so we used to use the hand. Now, that is a wrong technique. It has to be very sharp dissection, and
Absolutely.
we must not damage this fascia. We should do it diathermy or fine scissors, but absolutely sharp dissection. and the whole fascia should come out as an entirety. In fact, it is said that the surgeon is an important prognosticator factor for rectal cancer. That is the challenge these days. Okay. Now this
Um,
is sorry.
just one other questions.
Yeah.
Suppose you have a tumor located in the upper rectum. Do you need
Yes.
to still do a complete total mesorectal excision?
No, no, I'm coming to it. I have a small slide. Thank you. Uh, so this is a laparoscopic view of a patient undergoing rectal cancer. This for the students. So this fat is the mesorectum, and the whole fat has to come out. This shadow is the pre-sacral fascia, which we should not breach because just beneath that is the horrible pelvic veins and bleed torrentially. This mesorectum has to come out. Now, by doing this total mesorectal excision, Mr. Heal from Basingstoke managed to achieve a very low local recurrence rate, so much so that people didn't trust him. So he got Professor McFarlane from British Columbia in Canada to come and do an independent audit of his good results, the single sector center experience. Now, coming to your question that how much rectum to resect, basically, if the tumor is in the upper rectum and we remove the entire mesorectum, that means we have to remove the entire rectum. That is much of a muchness. What the pathological studies have shown that for upper rectal cancer, if you cut the rectum 5 centimeter distally, the lymphatic spread in the mesorectum doesn't go beyond this 5 centimeter.
Right.
I drew this cartoon just to bring home the message that for upper rectal cancer, we do a partial TME, but for the mid and the lower third rectal cancer, we do a total mesorectal excision. Now, there's an arbitrary limit. What is the upper, middle, and lower? So a tumor within 6 centimeter from the anal verge is the lower third rectal cancer. 6 to 11 centimeter from the verge is midrectal, and 11 to 15 centimeter from the verge is the upper third. Now something about the nomenclature. Now, if the upper third of the rectum is covered by a peritoneal fold. So if your anastomosis is distal to the peritoneal fold, it is called as the low anterior section. And if anastomosis is above that, it is called as a high anterior section. Am I clear, Sanjay?
Yeah, I'm just wondering, you often hear terms called an ultra low resection and a trans intersphincteric
Yes, yes.
uh,
Resection,
operation.
yeah.
So, would you at
Okay,
any
yeah, yeah,
point in time?
yeah. Fine, fine. See, it is very difficult, and I've searched the literature a lot. Ultra low means very, very low, but how low is ultra low anterior section, and how low is normal low anterior section? There is
Right, right.
no definite, So, and essentially, if you have a very low rectal cancer, patient has received neoadjuvant chemo radiotherapy, just 1 millimeter of negative distal margin is good enough. And if the patient is young with good sphincter tone, we can actually do a colo-anal kind of anastomosis. That is ultra low. Intersphinctering means we can remove the upper one third or half of the internal sphincter and get the rectum as low as the dentate line to anastomose. This is for very, very low rectal cancer. I personally don't like it because no matter whatever people say, the incontinence, the bowel frequency is a bit too much.
I would have thought so because you're really an anastomosis. The mucosal anastomosis is to the dentate line, isn't
Right?
it?
Yeah. Plus, patient had got chemoradiotherapy. The bowel function is very not at all satisfactory, especially in a country where the access to the toilets are very limited.
I mean, the worst thing to do is having a perineal colostomy, isn't it?
Absolutely. Other thing I must tell the junior students is that for elderly man, say a 80 years man with a lax sphincter tone, even if the TME and LAR is possible, I mean, and resection and anastomosis is possible, but the bowel function is not that good. So in that person, you are jolly well justified to do a LAR, low anterior resection, but bring up the colon as an end colostomy. The quality of life is far better, far better.
And you mean leaving the stump behind?
You go down below the rectum, just staple off the stump, and bring up the colon and resect the specimen and do a colostomy. So leave behind the anal canal.
Right. Okay. So
But
you
for
don't.
the elderly people, the quality of life much better from my own experience.
Yeah, that's very important message to go around, actually.
It's like a Hartmann's, but very, very low Hartmann's.
Quite right. With the idea that you are never going to rejoin it. That's
Yes, yes,
an
yes.
end.
I mean, I wouldn't like an elderly man to go to the toilet at 2 a.m. at night
Quite
or
right.
five, 6 times a day. It's really
Mm,
pathetic.
right.
Shall I move?
So, yes, please, please go ahead.
Yeah. Now, something about that, I don't know whether the picture is okay or not. So, this is a laparoscopic view. This is the aorta, and this is the inferior mesenteric artery. And the left colic artery takes off here, and here is the superior rectal artery. Now, we routinely ligate the inferior mesenteric artery. That's called as high tie. But the problem is we can damage the superior hypogastric plexus, which can give rise to um, retrograde ejaculation in men and lack of orgasm in females. While low tie means ligating the superior rectum, which will not damage the nerves, but and the lymph node spread to the inferior mesenteric artery is less than 2%. So why risk damage the nerve? That is a general question. But then, if you do a low anterior resection, you expect the sigmoid colon to reach the levator ani and achieve a tension-free colorectal anastomosis. So unless you ligate the inferior mesenteric artery at the origin and the inferior mesenteric vein close to the pancreatic inferior border, the colon will not swing down to reach the levator ani without any tension. This is something that trainees must know. So there is no oncological benefit, but if you ligate the IMA, the anastomosis becomes far easy and tension free.
So, Dr. Rai, what about the blood supply? I mean, you're removing the superior rectal and the left colonic artery, isn't it?
Yeah,
So, if you
yeah,
tie off
yeah,
the
yeah. It is dependent on the marginal supply from middle colic.
right, and the one
If
that's
you're,
possibly, called the Drummond artery of Drummond,
yes, marginal artery of Drummond. If you're unlucky, the collateral where the midgut and hindgut arteries uh, join somewhere close to the splenic flexure, if that is dodgy, then you can get a colonic gangrene, left colon gangrene. I've seen just one or two such patients, but generally the collateral is one of the best in our human body, the marginal artery of Drummond.
right?
Yeah. Okay. I think I have one more slide. Oh, now I'm coming to your question. If you ask me some further questions.
Yes, what are the types of neoadjuvant treatment, and how do you choose which one to give? I mean, there are
You asked
plenty
me,
of
yeah, you asked me during that EMBI, so I thought I'll speak later. So here am I.
yes,
Uh,
yes, right,
so generally speaking, there has been frustration with the high incidence of local recurrence after a rectal cancer surgery. So much so that Socrates had prayed to God that God, if you want to take me, please do not take me through my pelvis. He may be referring to rectal cancer or prostatic cancer, but local recurrence, the pain of the death is terrible, hydronephrosis. So Surgeons have been frustrated over the years to decrease the local recurrence. The total mesorectal excision has had a huge impact on the surgical management, but concurrently around same 30 40 years, the chemoradiotherapy have also increased. Traditionally, the American studies, they were giving radiotherapy after the surgery, but in Europe, especially in the Stockholm area, Scandinavian, they were giving it before the surgery. And the beauty of preoperative radiotherapy is because it's oxygenated tissue and radiotherapy works by generating free radicals. And as the rectum is still in situ, the small bowel doesn't come down to the pelvis. So damage to the small bowel is much less if you are using a neoadjuvant radiotherapy. So one of the early landmark trials which the students must know, just a German rectal cancer trial, they were they gave neoadjuvant chemo radiotherapy, which is capecitabine or 5-FU at a low dose. The chemotherapy in these doses are not really chemotherapy doses, but it is act as a radio sensitizer.
Sensitizer. Yep.
So basically, patients get the radiotherapy over 28 fractions, 5.5 weeks. And after a delay of 8 to 10 weeks, 2.5 months, then the surgeon goes in and does the total mesorectal excision.
So why do we wait for that long, Dr. Roy?
Yeah.
Why
Yeah.
8 weeks of wait?
See, the radiotherapy is like a hit, and then the tumor becomes smaller and smaller over the as you wait. You want if the on the MRI, if the tumor has invaded the MRF, so if you operate, you will get a positive margin. So you're given chemoradiotherapy, you have to wait for the tumor to shrink. The studies have shown that it shrinks the maximum within 7 weeks. So anytime after 7 weeks, you can operate. So generally 8 to 10 weeks, people wait for edema to subside, etc. And this particular trial showed that as compared to the control, the, there was a significant decrease in the local recurrence. But what is important is no improvement in overall survival. So patient gets a tablet of capecitabine, gets a radiotherapy, not over the weekends. And this is the standard treatment. We also call it NACRT, just a short. And the other strategy, which became extremely popular, but before that, I'm sorry, the German trial, if you look at the local recurrence, it is much lesser. But after 11 years of follow up, the overall survival didn't change between pre and post operative hemorrhagic. This is the frustrating bit. The next trial which the student should know is the uh, sorry, this I have already spoken that we have to wait for 8 to 10 weeks gap and
Right.
then to shrink the tumor. Now, this is the neoadjuvant short course radiotherapy. There is no chemotherapy involved in this, just a short course, just 5 days. And the original trial setting was you can operate after a week, but then later the Stockholm 3 etc. came up. You can operate after a month to achieve some kind of a tumor regression. Once again, there was no improvement in the overall survival. That is the problem with this kind of radiotherapy. Am I okay with the standard of
Um,
talk?
it's a worry because in a long course radiation, you wait for 7 weeks for
Yes.
optimum
Yeah.
tumor shrinkage.
Uh,
Why don't we do the same for a short course radiation?
yes. Yes. There is something called as biological equivalent dose. Now, for the long course, patient gets just 2.4 gray per day, but in the short course, they get 5 gray per day. But apparently, biologically, they are similar. So then the people started questioning that if we give short course, especially became COVID, it became very popular, and you wait longer, then you will have the same tumor shrinkage. That was tested in the Stockholm 3 trial. So, but the problems are the response to the radiotherapy are rather worse as compared to the response after long course. So, surgically operating after a delay after short course is technically a little challenging. More bleeding and breach of the mesorectal fascia. Okay.
So where would you choose a short course? Where would you choose a long course?
Yes, I have made a small summary later on, but
Okay, great.
we share
Okay,
with you the
we'll
historical.
wait for that.
There's a historical journey that I'm trying to discuss that none of the studies of neoadjuvant radiotherapy with or without chemotherapy, and this chemotherapy, mind you, it's a low dose chemo as a radiosensitizer, none of those showed any increase in overall survival. They all decreased local recurrence, but none increased the overall survival. So, if we add neoadjuvant chemotherapy in its full dose, will it help improve the survival? Something which we saw in the evolution of treatment of gastric cancer. Okay, the same strategy was adopted, and this is called as total neoadjuvant therapy (TNT). It came into vogue just maybe 7 8 years ago. Total neoadjuvant therapy. This is more relevant for our country because patients in our setup usually come rather late. So I'll just take you through three important landmark studies. So before that, there is some terminology which the surgical trainee should know. When we say induction, it means chemotherapy followed by radiotherapy. Radiotherapy is the index. If you give chemotherapy before, it's called induction. If you give radiotherapy and then the chemotherapy, it's called as consolidations. These terms will crop up more, so I introduce these terms. Now, locally advanced rectal cancer. These are the cancer which have high chances of local and systemic recurrence. Once again, here is the importance of MRI. There's a large bulky tumors with more than 3 or 4 mesorectal nodes, enlarged lateral pelvic lymph nodes. MRF is involved, presence of the EMBI, which most of our patients are locally advanced. These patients should be considered for some form of TNT. Now, this is a very busy slide. I have made this just to document the various TNT trials, but the importance are highlighted with the orange. The Prodige 23, the Rapido, the OPRA, organ preservation in rectal adenocarcinoma, and this orange line is the line for surgery. So in all this TNT, everything is done before the surgery. In Prodige, it is followed up with the adjuvant chemotherapy, and in Rapido, no chemotherapy is given after surgery. This is just a very basic sketch. Now, I'm now
It's a bit ironical that Rapido you are expected to wait for 24 weeks. Just a
yes.
sort of
Now of these trials, I've just picked up three important trials: Rapido, Prodige, and the Opera. This is the actual trial design. The student did not know this, just only the highlighted in the red. So Rapido is very good. There's 5 days of radiotherapy, and then you give chemotherapy and then surgery, and that's it. No further treatment. The short course, chemotherapy and surgery. While Prodige 23, it was a French trial. So if you look at Rapid, only two chemotherapy are using 5-FU or capecitabine and oxaliplatin. But Prodige is a French trial, and the French oncologists had developed FOLFIRINOX, 3 chemotherapy for pancreatic cancer. So they are very comfortable with FOLFIRINOX, triplet chemo. So they did the study. So proper chemotherapy, then long course chemoradiotherapy, then surgery, then adjuvant chemotherapy. Very long, almost 11 months of treatment. This is the Prodige 23. Opera was done in MSKCC, Memorial Sloan Catering, and the basic intent was to achieve as much tumor regression and try to avoid surgery like watch and wait protocol. They had two arms. One was induction, that means chemo followed by long course chemoradiotherapy. Other was consolidation, that means long course chemorad followed by chemotherapy. So Rapido, Prodigy 23 and Opera. Now just a simple slide. These are all long-term studies after 5 years, 7 years. In Rapido, there were decreased systemic recurrence, but the overall survival didn't really change. Very surprisingly, paradoxically, the local recurrence was worse. And this is what we also saw is that after a long delay between short course and surgery, the tissues become so tough, we tend to breach the mesorectal fascia. So more tumor spillage in the pelvis. In contrast, if you look at the Prodigy 23, which is more intense, a decreased local recurrence, but for the first time in the history of rectal cancer, it managed to have a survival advantage by almost 6%, with the local recurrence is very less. And if you consider the OPRA, the organ preservation watch and wait was more in the consolidation. That means long course chemoradiotherapy followed by proper chemotherapy achieves more watch and wait. Overall survival between the two arms is not different, which means the sequence of chemotherapy, either before or after chemoradiotherapy, do not influence the survival. This is a very important take home message. Does not influence survival. So, Dr. Devakshi, I have made a very simple, like a ready reckoner for the students. We
Right.
have to do a MRI pelvis, short course, very early, T3 tumors, few mesorectal nodes, MRF is free, and you may give short course radiotherapy. But very expert surgeons may question that if the MRF is free, I'm a fantastic surgeon, I may not give the short course. But maybe for the beginners, some short course is useful. Long course chemoradiotherapy, the German trial, in which the MRF is involved, few nodes and no EMVI, it is NSCRT is still indicated. You wait for at least 8 to 10 weeks and then operate. And the total neoadjuvant therapy for locally advanced tumor, we have to do it. The best way to decide what is good for a patient is to have a multidisciplinary meeting. A practical aspect, as a large number of our patients come locally advanced, with impending obstruction, the colonoscope could not be passed, but the MDT has decided a TNT which takes few months. So whilst on TNT, if the patient gets obstructed, it's a very bad, difficult to manage. So such patients should be first offered a laparoscopy assisted loop sigmoid colostomy, followed by TNT, and then the surgery.
I have a question. Why not a loop ileostomy?
Loop ileostomy, supposing if that valve is, the ileocecal valve is competent, it may not defunction the whole thing.
Absolutely.
So we have had patients where the whole of patient had ileostomy elsewhere, and when they came to us, the whole colon was hugely distended, lot of stool. So that can be problem. So we tend to
Right.
prefer loop sigmoid.
Um, doesn't that interfere with your later mobilization
No,
of?
no, no, not really. So basically close the stoma, put it back, and then either do laparoscopy or laparotomy. And what I tend to do is I bring out the ileostomy through the same opening.
Right.
So
Okay.
if the patient has ileostomy on the left side, that means he must have had a loop sigmoidous first thing before the neoadjuvant treatment.
Okay.
That
So
is
why do you do a loop ileostomy? I mean,
no. Say patient has a low anterior section. Oh, why
yes.
asking? So I'm coming to it.
Okay.
So I think we covered the chapter of the discussion on the neoadjuvant treatment. So
Except at some point in time, I will ask you about the use of immunotherapy, particularly for
yes, yes, yes. Sure,
uh,
sure, sure, sure. So coming to the
bladder.
surgery, after the everything is over, new adjuvant, chemoradiotherapy, patient always, although there is ample evidence of saying that there is no need for mechanical bowel prep, but there is a must. You have to, for low anterior section, every patient needs a mechanical bowel prep, and then after a colorectal anastomosis following neoadjuvant chemotherapy, the approximate anastomotic leak is 20%. So you have to do a loop ileostomy, no matter whatever the patient, whatever people say. And especially our stool bacteria is horrible. Most of us have MDRO bugs. So loop ileostomy is mandatory.
Right. So how do you then? I mean, you've done a loop ileostomy.
Yeah.
When do you close it, and how do you close it?
Okay. So there is some. It depends on each patient, individual patient. Supposing patient had the rapido, and patient do not need any adjuvant chemotherapy, then after 3 months is the recommended. At least 8 to 12 weeks. After that, we should close the loop ileostomy. If
Right.
the medical oncologist decides no, this patient needs adjuvant chemotherapy, which can take 4 to 5 months, then wait for 4 to 5 months. Then after the conclusion of chemotherapy, wait for a month, and then close the loop ileostomy. So what I say to the patients that after the surgery, if you do not need chemotherapy, the stoma will close after 3 months. And if the patient needs adjuvant, then you will have the stoma after 6 months, just to keep it very simple. Now, when we want to close the loop ileostomy, we have to ensure that the colorectal anastomosis has healed properly. And if we do a digital rectal examination, that is good enough. But to be absolutely sure, we can just do a gastrographin, water soluble contrast enema, yeah, and a fluoroscopy, very cheap, and that shows a beautiful picture. Now, the question that you asked me before, if the colonoscopy had shown a impossible growth during the initial evaluation, and now the patient has come to me for ileostomy closure, I jolly well ignore the gastrographic enema and do a colonoscopy just to see whether the anastomosis has healed, plus evaluate the proximal colon. So the
Right.
colonoscopy will do both, and a digital rectal examination will also ensure there is no anastomotic stricture, which can happen if there is an occult anastomotic leak which heals by fibrosis. And the
Right.
optimum time is 8 to 12 weeks after the surgery.
So I have a question.
Yeah.
When do you decide to do an abdominoperineal excision? I mean, you've talked about an elderly patient
Right, right,
who,
right, 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 right. Okay, okay. See, if the on the MRI is on the say digital rectal examination, when you are examining the patient in the OPD clinic, then you put it's very low rectal cancer. Ask the patient to squeeze your index finger by the sphincter, squeeze the sphincter, your finger, and if you feel that the tumor has come to the anal canal, the patient needs a AP excision, abdominal perineal excision. On the MRI, if it is a higher tumor but it has invaded the levator ani, then also patient needs a AP resection. That is must. Uh, so I want to share with you a small cartoon. So the levator ani, the orange line, becomes the external sphincter, and the internal muscle continues as the internal sphincter. So if the tumor is somewhere here, I would prefer a APR, AP abdominal perineal excision. Now, in the conventional APE, the surgeon used to go, the perineal surgeon go skirting the external sphincter. He will enter the levator ani and go like this. In this route, he may damage the tumor perforation, and cause high chances of local recurrence. So that is what they found when they compared the local recurrence after APE vis-a-vis local recurrence after a low anterior section. And this brought some change in the management, and it's become fairly standard now in the sense that the surgeon, the perineal surgeon, instead of entering the levator, he or she reaches the levator ani and then goes underneath the levator ani till the lateral pelvic wall and then perforates the levator ani. So he removes a huge levator with it. That is called as a extra levator abdominal perineal excision or ELAP. The person who made it very popular was a guy called Holmes from Sweden, and this is one of his publications. If you look at the standard APE, at the level of levator ani, there is a waist. It's called Morrison waist, but here is the high chances of tumor perforation. But if you look at the ELAP specimen, as because you have taken the levator ani and the fat, it looks like a cylinder. This surgery is also called as a cylindrical APE. So this is a
But do tell me something, Dr. Roy. I mean, closure of the perineal pelvic diaphragm after an ELAP.
yes, it is. It is virtually well, you can't close it because you have taken out the interlevator. The options are the biological mesh,
Right.
which you can stitch. Is little expensive, but it's available with difficulty. The second option is to get your plastic surgeon friend to do a gluteus maximus flap or some kind of a rotation advancement flap. So the way to do ELAP is to do the abdominal portion either laparotomy or laparoscopically, create the stoma, turn the patient prone, make him jackknife or leg apart, then deliver the specimen through the perineum, and then the plastic surgeon comes in. So be prepared for a whole day in the operating room with plenty of food for your colleagues. Otherwise, it takes 7 to 8 hours.
Yes, quite. So, so what is your preference, a biological mesh or a rotation flap, getting your plastic surgery
I
lesion?
have not used a single biological mesh, I have to be honest. Whatever I have done is with the help of the plastic surgeon and rotation plan. It's much cheaper and easily available. And accept a perineal hernia of around 30% if you do not close the levator ani.
Even with a gluteal maximus rotation flap?
No, no, that decreases the. I don't know the incidence of perineal hernia after a flap, but if you do not close the levator at all, then the chances of perineal hernia is 30 to 40%,
Yes.
not 100%.
Yes, but it's a very high incidence and it's a bad place to have a hernia, isn't
Yeah,
it?
yeah, true, true. But generally, patients don't have problems. Generally, I've seen it's not
Um,
ideal.
right. Um, the other question is you tend to hear a lot about total TNT, and there was a trial where 90% of patients in that trial had a complete regression of tumor, particularly in that subset
Yes, yes.
where people had an MSI-H variant. So, if you can just tell us something about microsatellite instability.
Okay. See, basically, this micros. See, our when our DNA is when the cells are replicating, the DNA strands get duplicated. But during the process, there can be mismatch. So there are mismatch repair genes, but those genes can be defective. So the mismatch can happen. Now, to know whether the patient has a mismatch repair gene, one has to do a PCR, which is not easily available and expensive. The other way is to look for the proteins which will get generated if there is a mismatch repair of the DNA. So that is picked up by the immunohistochemistry, which is cheaper and easily available, which we call as microsatellite. So microsatellite instability, MSI. It can be stable, it can be high. That means high means the MMR genes are deficient. And generally, MSI high tumors have a better prognosis. And if the patient has MSI high, one has to look and exclude for the Lynch syndrome. So I have made just one slide on this issue. The MSI high tumors are more prevalent in the right colon cancer, 15 to 20%. But in rectal cancer, it is less than 5%. In this landmark phase 2 study from Memorial Sloan Kettering, this dostarlimab, this immunotherapy, it's basically a anti-PD-1, uh, platelet derived. So basically, this receptor, it blocks the action of the T lymphocytes, which can kill the cancer cells, and that is where this immunotherapy works. And as a general knowledge, immunotherapy works only in MSI high tumors. Now, unfortunately, in contrast to colon, rectal cancer, only 5% patients will have MSI high. In this subset, this study used dostarlimab. They took for every 3 weeks for 6 months, total 18 injections, and they were followed for 12, almost 2 years, and all had complete response. All. This is a beautiful news. The same group with a larger cohort published their study this year. So around 89% patients remain disease free without treatment, surgery, without chemotherapy, without radiotherapy for a follow up of 2 years. This is brilliant.
That's fantastic news, isn't it?
Yeah.
Is there a bit of difference between um immune therapy for the right and the left side of right-sided colon and the left-sided colon?
Well, I think the bevacizumab and cetuximab, there is some difference. CALGB trial. Uh,
Yes.
the bevacizumab works more on the right side by cetuximab, the left, or it could be reverse. I'm forgetting it actually. But they are not really the immunotherapy. They are more of targeted therapy.
Mm, true. So, if there are any, shall we take some questions? We have some more slides, Dr.
No,
Man.
I'm finished.
So, open to any questions, guys. I mean, if you have any questions, now's the time to uh, put them across. Open for any questions, and we are on live. Um, so, Shilajit, if there are any questions, Rudrajit, if there are any questions from uh, the general population at large, so we can take them right now. Right, if we, while we are waiting for the questions, just a bit of a uh, prior notice for people who are on CCC. Um, we will have a test mock OSCE examinations running tomorrow. So we will have 10 OSCE questions, 4 minutes each to answer. So that's a trial sort of a thing. It's a test sort of a thing. And we'll come in with the answers either on Wednesday or Thursday. Shilajit will keep you informed. Any other questions, Shilajit and Rudrajit?
No, sir, there is no questions in the YouTube.
Okay, how about guys on the Zoom? CCC, any questions from you? Think about it. If you have questions later, I think Dr. Manushroy has done a very extensive and exhaustive uh, discussion on anorectal cancers. I think, um, thank you, Dr. Manushroy. That
Thank
was
you.
brilliant. Um, So if you have any questions, do post them, and I'm sure Dr. Roy, uh, if you think of any questions later, I'm sure if
Of
you
course.
post it, Dr. Roy will be only too happy to answer. Isn't that right?
Absolutely.
Well, thank you, Dr. Roy. Thank you
Thank
so
you.
much. That was a brilliant, brilliant, brilliant exposition. We will hope to repeat uh, YouTube Live with other topics. Um, and Dr. Roy has a number of classes with us on CCC. So you might want to, if you're on CCC, you might want to go through that as well. So if there are no other questions, then only thing to do is to thank Shilajit and Rudrajit and thank Dr. Manushree for taking time out for this.
It was an absolute pleasure. Thank you very much.
You're welcome.
Thank
Don't worry, we'll grab you again.
you. Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you. Good night, everybody.
Good
Good
night.
night, sir.
Good night.